your microphone up.
All right, good afternoon, everyone. Thank you so much for being here for this first meeting of the Health Policy Commission Advisory Council for the 2019 to 2020 two-year term. I'm David Seltz, Executive Director of the Health Policy Commission, joined by Colleen Nelson-Meyer, the Deputy Executive Director of the Health Policy Commission. Just want to say how pleased and excited I am to convene this group again. We have a number of new faces and new members who are joining this advisory council for the first time today. Really a great opportunity as we think about the two-year cycle for the advisory council in terms of both bringing back some great members who have been with us since the very beginning, since 2013, and were part of our inaugural advisory council group. But also a great opportunity to bring some new voices and perspectives and expertise to this group. And so I'm very excited to refresh this advisory council and to also have some new areas that are going to be, I think, emerging priorities for the Health Policy Commission and the work of the Commonwealth, particularly in areas of pharmaceutical and biotech innovation, public health and health equity, and social determinants of health, as well as some of the challenges that our small businesses in particular are facing and consumers around affordability of healthcare that we've seen in the data. Also very pleased to invite for the first time some of our sister agencies who will be a part of the advisory council moving forward. So I'm very pleased to have, we've had Mass Health representation since the very beginning, but pleased to have representatives from the Health Connector and the Group Insurance Commission who are going to be part of this advisory council moving forward. I think in the spirit of collaboration and coordination that I think all of our agencies feel in terms of our shared goals in terms of healthcare transformation and challenge. So they are going to be active members advising the Health Policy Commission, but I think also active listeners in thinking about all of your perspectives and your priorities moving forward. I'm also, before we go around and do introductions, and I do want to spend a moment doing that because of a lot of our new members. First, our classic tutorial on the microphones. We do live stream these meetings, and so I really ask that you do use the microphones whenever you're speaking. They are all on, as I can see. Green means go, and the microphones are live. You can just leave it at green and just push the microphone away from you. But if you do want to turn it on, just press the button and give like a good 1 Mississippi before trying to press it again, because it does a slight delay on the microphones.
I'm also, before we get into going around the room and just introducing ourselves, I am so pleased to have a new commissioner of the Health Policy Commission board here today. So I think first I'd love to have her introduce herself and her background, introduce her to all of you, and so great that you were here today to join us. Yeah.
Hi everyone, my name is Barbara Blakeney and I am filling a slot for innovation on the commission. I've been a commissioner for a little over a month, so please be kind to me. Still learning a great deal about the program. I've spent 3 fantastic hours this morning learning more about the work that the commission does, and I have to say that with each passing engagement with staff, how impressed I am with their skill, their knowledge, and their enthusiasm for the work that they do. So I'm thrilled to join the commission, and I'm thrilled to be part of this work going forward. So thank you.
Thank you. So the first couple of slides here just are some background on the Health Policy Commission. I think I won't walk through them because I think hopefully all of you know why you're here and what the Health Policy Commission does. But I think just to reiterate that a core part of our role and how we think that we can impact and influence change in the healthcare market is around this idea of convening and this concept of bringing together all of the stakeholders to discuss and to commit action on some of the biggest challenges that face us in terms of healthcare affordability and costs. And this is a really prestigious group of individuals around this table. And I know that each one of you have a lot of demands on your time, and it is not lost on me, the board, or the Commonwealth that you are willing to volunteer your time to be a part of this group. This group is invitation only, and I know that every one of you has a commitment to the mission of the organization and the mission of what we're trying to accomplish in this Commonwealth. And so this is important work for you, and not something that I think is just an opportunity to me to talk at you, but really an opportunity for us to talk with each other, and beyond just these couple of meetings a year. And I think that's another thing that I wanted to just say at the outset. I think we typically meet 3 to 4 times a year, and definitely will send you information through email and other opportunities throughout the year. But want to first make a stronger commitment to tap into you in terms of ongoing engagement with the work of the HPC to the extent that you have the time and interest and are willing to do so. We would welcome it and encourage it. And so as we go through today's presentation and throughout this year, would ask that you think about those areas that you or your organization is most interested in and where you'd be willing to meet with us off cycle and share and engage in this work. And so I want to put that out there as an ask as we go into this next 2-year session of the Advisory Council. So with that, I think it's worth going around the room and ask everyone to introduce themselves. I think typically we just say our names, but given that there's so many new members, maybe just a minute about your organization or where you're coming from and your perspective. And I think specifically for the new members of this group, would ask that you just say a word or two about what some of your priorities are going to be as we launch into this 2-year cycle. So with that, I'll turn it over to you, Diane.
Hi everybody, Diane Anderson. I'm the CEO of Lawrence General Hospital, returning member, and you probably all, most of you know, we're a regional medical center in North Boston, Worcestershire Hospital, also a member of ACO, so very interested in all the dynamics that are happening as far as market shifts, and of course appropriate compensation for all hospitals.
I'm Cheryl Clark. I'm a health equities researcher and physician at the Brigham and Women's Hospital, a returning member, and very interested in the upcoming work that will be going more deeply into health equity and social determinants.
Hi, Erica Wilkinson with Blue Cross Blue Shield, filling in for Mike Caljo. I am the Director of Government Regulatory Affairs at Blue Cross. I think for the next 2-year cycle, we are interested in continuing looking at the possibilities with alternative payment methodologies, as well as focusing on pharmaceutical costs and out-of-network payments and the impact on our members, as well as our ability to create lower-cost products.
I'm Keenan Creed. I'm the Chief Medical Officer for the Northern Region of Waystate Health, which covers Franklin County. We have different challenges than most other health care organizations in Boston, Cambridge, and surrounding areas. We're in a rural population around a very rural area. We have very poor access to primary care, physicians, hospital that cover, it's about 100 beds. So half of those are OB beds, but we have 200 physicians affiliated with the hospital, either salaried or private, who also practice in the region that I'm responsible for. We have a large opioid use disorder problem. We have areas with no cell phone signal or internet. So we have a lot of challenges, and we have to be a little bit creative about how to provide access to care.
David Madioto, returning member, Mass Association of Behavioral Health Systems. We represent 47 psychiatric substance abuse and substance abuse facilities throughout Massachusetts, from the Berkshires to the Cape, including general hospital psych units, freestanding substance abuse facilities, and freestanding psychiatric facilities. And our two or three of our biggest priorities are at this coming session are access, of course reimbursement, better reimbursement, and workforce. Workforce is a huge challenge for us now, filling positions. Thank you.
Hi, Marcy Sindel. I'm Chief Strategy Officer for Atrius Health. We're the largest independent medical group in Massachusetts, serving over 700,000 patients from Chelmsford down to the Cape. And our interests are largely around value-based payment reform and using that to drive up quality and make care more affordable. And we're very interested in moving to lower acuity sites of care, moving care to where the patients really want to be and where it can be provided well.
Good afternoon, I'm Melissa Schuyler. I'm pleased to be here on behalf of Dr. Mike Wagner, CEO of WellForce. WellForce is the parent system for Tufts Medical Center, Melrose Wakefield Healthcare, and Circle Health up in Lowell, and the physicians that we represent from Cape Cod all the way up to the New Hampshire border. Our focus is going to be on continuing to build out our clinically integrated networks and driving care into the community. We're happy to take up some of the issues that everyone else has laid on the table. Thank you.
Mississippi. I have no patience. I'm a new member, Chris Schuster. The last 22 years I've been a CEO in Massachusetts hospitals, in a dish hospital, in a rural hospital, and now the last 15 years in a community hospital, Emerson Hospital, which services Middlesex County largely, about 360,000 residents. And I'm very interested in collaboration as opposed to competition, and how we can find partnerships to lower the cost of care and work together for things that are important, especially finding ways to ensure that we have a good, strong workforce going forward.
Good afternoon, Pat Kelleher with the Home Care Alliance, Mass. I'm a returning member and glad to be reappointed. We represent 175 home health and home care agencies across the state. Our interests are post-acute care, changing face of that, changing landscape, especially as it relates to value-based purchasing programs. Our members are also highly engaged in providing non-skilled care in the home, so long-term services and supports, and social determinants of health. I think our member agencies see on the front line some of those intersections between nutrition and medicine and healthcare and socioeconomic issues. So we're really interested in how we can even be more attuned to those issues and supportive of the partners around this table. Our major issue, as David just said, is also workforce, finding enough workers to meet the demand for care in the home, both skilled and non-skilled, and how the workforce obviously intersects with rates.
Hi, Monica Sonny here on behalf of Dan Side, Assistant Secretary for Mass Health. I'm sure you all know Mass Health is the Medicaid insurance program for Massachusetts. Happy to be back and hear what everyone has to say.
Hi, I'm Meg Hogan. I'm the CEO at Boston Senior Home Care. I also represent 26 aging service access points. Our mission being to be able to keep elders and disabled adults in their homes for as long as possible, many of whom are clinically eligible for nursing home placement. Our area of priority continues to be to collaborate and innovate so that we can keep people longer at home. Right now we're averaging about 2.8 years after they're clinically eligible, and also to really deepen our relationships with people in this room and across the care continuum so we can do that effectively.
Good afternoon, everyone. I'm Corinne Pavlos. I'm the Executive Director of the Massachusetts Public Health Association. So, of course, I was thrilled to hear David in his introduction talk about the prioritization of public health and health equity. Those are priorities that we share, and of course, addressing the social determinants of health and health-related social needs. We convene an alliance called the Alliance for Community Health Integration, ACHI, which is a wonderful acronym. I hope you hear about more. And in that role, are very interested in helping to provide a vehicle for linking health care providers and systems with community-based organizations that are out there and prepared to respond to referrals for health-related social needs. One of the reasons for that and our interest in doing that is that there are across this Commonwealth those community-based organizations that have long time expertise in both accepting those referrals but also community building, and we're really interested in making sure that that role is respected rather than not.
Good afternoon, my name is Bonnie Gilbert. I'm a board member of Greater Boston Interfaith Organization, GBIO, and I'm one of the co-chairs of the healthcare team. I'm a new member. Thank you for having me. And for those of you who don't know GBIO, we are an organization of about 43 institutions, religious and otherwise. We represent about 40,000 individuals. We are best known for our work in healthcare, although we also work in criminal justice and housing. We've been involved with healthcare since the early 2000s all the way through. Our goal or our interest really rise around the patients and the consumers and out-of-pocket costs and access to care. So right now we're really focused on pharmaceutical costs, deductibles, other costs not being counted towards your maximum deductibles, surprise billing, and mental health care access and costs.
Good afternoon, my name is Audrey Gasteyer, and I'm the Chief of Policy and Strategy at the Massachusetts Health Connector, which, as I'm sure many of you know, is our state's health insurance exchange. We've been around since 2006. We currently cover about 285,000 individuals in the non-group market in Massachusetts, or about 80% of the individual market here. And we feel pleased with a lot of the progress Massachusetts has been able to make on coverage and affordability in terms of premiums and access, but feel like there's still more work to do. And even though we kind of lead the nation in certain metrics, we feel like there's still additional measures we could take to make sure that premiums are really affordable for people and get the remaining uninsured into coverage. We still have this remaining 3% or so here in the Commonwealth. In terms of my particular areas of interest this year, and a new member, thank you so much for inviting my participation. We are really looking to try to bring some of the dynamics that have been successful in the individual market to the small employer market in Massachusetts. We were designed to serve both individual and small groups in Massachusetts, and feel like we have some tools and learnings that we can really bring to bear to help make sure that we're bringing the same affordability and value proposition to small employers in the Commonwealth, who we've been later to get to, but are certainly in need of the same kinds of interventions that we feel like have worked on the non-group side. So that's a key area of focus for us, and really look forward to talking with this group and learning from everyone's expertise and how we can continue to advance coverage in the Commonwealth.
Hi, I'm Ashley Monroe-Lee. I'm the Chief of Staff at the Group Insurance Commission, here today on behalf of Dr. Roberta Herman, who
sends her regrets for not being able to be here. We also are a new member, and as most of you know, we are the largest employer purchaser of healthcare in the Commonwealth. We have 4 main priorities for this year. The first being reining in pharmacy costs, the second being intervening on provider pricing, third being broadening our product portfolio to consider things like ACOs, and the fourth being modernizing our internal operations and processes to better serve our members. Thank you.
Hi, my name is Julie Pinkham. I'm the Executive Director for the Massachusetts Nurses Association. We represent about 23,000 registered nurses, primarily direct care, and all facets of healthcare in the Commonwealth of Massachusetts. Our main, obviously, interest is in any emerging trends and its impact on our ability to deliver safe patient care.
Hi, my name is Alyssa Vangeli. I'm co-director of Policy and Government Relations at Healthcare for All. I'm filling in today for Amy Rosenthal, our executive director. And while Healthcare for All is not a new member to this committee, Amy is, so she looks forward to attending the next meeting. Healthcare for All is a statewide organization. We advocate for health justice by working to promote health equity and ensuring access and coverage for all. Some of our priorities include promoting health equity, of course, by addressing health-related social needs and social determinants of health. We're a member of the Alliance for Community Health Integration, a very proud member. We also have priorities around affordability for consumers, both in terms of premiums and out-of-pocket costs. Concerned about pharmaceutical spending and the impact of costs, and wanting to work toward protecting consumers in situations of surprise out-of-network bills.
Good afternoon. My name is Steve Walsh from the Massachusetts Health and Hospital Association. I was thrilled to be reappointed today, so thank you very much for having us again. Look forward to working with this group as we develop public policy initiatives, making sure that we continue to provide the greatest possible care to our patients.
My name is Laura Pellegrini. I'm president and CEO of the Mass Association of Health Plans. I represent 17 health plans in the commercial market, Medicare, and programs such as Medicaid, the school program, and Medicare. We are very proud of what we've done for our people today in providers incorporating most of our.
Or can you grab Chris's microphone? It's just not big enough.
Folks hear me. We're very proud of the work we've done in partnership with government providers in covering most of our state's citizens. But we know affordability continues to be a major challenge. And recently, one of our business partners actually surveyed their members, and healthcare costs was the #1 issue for our community. So we really rely on the work of the Health Policy Commission and the work they do to identify cost drivers. We've done great on the cost benchmark, but we still have one of the highest healthcare costs in the nation. We're working off of a very inflated base. So as they identify ways that we can rein in healthcare costs, whether it be pharmacy spending or other matters, that's where MAP's focus is. At the end of the day, it's the price, and that's how we're going to make healthcare more affordable, is to focus on those issues. So thank you.
Thank you. I'm Christopher Carlozzi. I'm NFIB's Massachusetts State Director. NFIB represents small independent businesses in Massachusetts. All sorts of industries, but the average size of our member has about 5 workers. And I often hear stories from them on double-digit premium increases every year, anecdotal stories about how high healthcare costs are. So for them, that is their #1 issue. It's a top priority for small businesses. And if you had to ask me the one issue that we were most concerned about, it would be healthcare costs, and most importantly, affordability. We've tackled coverage, we've tackled quality of care, and now it's time to finally tackle costs for small businesses and their workforce. Thank you.
Hi, I'm J.D. Chesloff, the Executive Director of the Massachusetts Business Roundtable. We are a group of CEOs and senior executives from generally large employers. So I also hear about the cost of healthcare. It's a little bit different perspective than what Chris and John had from the smaller employers. Its cost really as it relates to premiums is what I hear mostly. We are getting involved through actually an initiative with the HPC to try to control costs really around looking at emergency room visits. So it's a way that we can engage, but it is a little bit of a different perspective, but certainly a shared concern.
Good afternoon, I'm John Hurst, President of the Retailers Association of Massachusetts. I am a returning member, thank you, David. Our organization's been around now we're in our 101st year. We are, of our 4,000 members, 99% of them have 50 or fewer employees, so small group premiums is our top issue. And historically, for the last 13 years, we have, this time of year, for April 1 renewals, we've always surveyed our members. Over that 13-year period, we've had an average of 11% increases each year. This year, the good news is this year it came in at 6.7, significantly down from 11, but the bad news is that's more than twice the state benchmark, so more work to do.
I'm Ron Dunlap, a cardiologist at South Shore Hospital, past president of the Massachusetts Medical Society. We're particularly interested in healthcare delivery and access. I've, in this past year, got the AMA and Mass Medical Society to focus on ACOs, particularly looking at risk-bearing ACOs. So we're very interested in the fact that physician-led ACOs did much better in saving money than large systems. And given that we're in an area which is largely consolidated, this year I wanted to try to focus us on what factors drive those costs and how we can bring those down, because ultimately if they're not successful, the Affordable Care Act and a number of other things fail. Our other concern is the effect of all of that organization on our workforce and the welfare of physicians. There's a burnout phenomenon that's largely associated with administrative burden, electronic health records, and so on. And given that we have an aging population, we have workforce issues that will be, by 2025, I think they predict that we'll have 90,000 physician shortage. So I think given that the demands are going to go up with the aging population, we really need to keep people in the workforce longer, and we need to have the physicians be healthy so that they can have more time to engage their patients that we expect to do value-based care and have good outcomes.
Good afternoon, I'm Rich Buckley, also a returning member. Thank you, David, for having me back. I look after global corporate affairs at AstraZeneca. We are a research-based, science-led biopharmaceutical company with deep roots in Massachusetts, both manufacturing and R&D, among other things here in the Bay State. We invest nearly $6 billion a year in research and development, primarily in the areas of oncology, respiratory, cardiovascular, renal, and metabolic disease. And so therefore, our policy priorities usually focus around policies that are both pro-patient and pro-innovation. Thank you very much for the opportunity.
Great. Thank you all for taking the time to go around the room. We don't typically do that at these advisory council meetings, but since this is the first meeting of the 2-year session, I thought it was a great opportunity, and I think we will document all of the priorities that you just documented and have that be part of our recap of this meeting that I would report back to the board as well. There are a couple of other brand new members that weren't able to join us for this first meeting that I just do want to call out. Dr. Abby Selniker, who's a partner at Third Rock Ventures in the innovation and biotech and pharmaceutical space, as well as Dr. Donna Mosh, who's the president and CEO of the Massachusetts Association of Mental Health. And finally, Miss Emily Stewart, who is the CEO of Casa Esperanza. Very pleased to have their voices and perspectives as part of this council in future meetings. Also just want to say, I think going around this room and hearing from all of you, one of the great advantages of this group is an opportunity for you guys to network with each other. It's not often that all of these different people can be in the room, and I've heard a lot of different perspectives and wanting to and eager to make collaborations and connections across the healthcare industry and across these stakeholders. So please do take that opportunity to meet and converse and network with each other. And I think this always provides a great opportunity to see each other and to share what's going on in each of your organizations and in your lives. So for the meeting today, we typically have an hour and a half of these meetings, and we try to keep to that schedule as much as possible. For today, just to give a little sense of the agenda, do have some housekeeping items that I just want to make you aware of in terms of the business and organization of the HBC, some publications that are in the pipeline to be released soon, and interested in any questions and feedback on that. But really the bulk of the meeting today is going to focus on your input and feedback and guidance to us in terms of our research agenda. This is obviously in that 4 buckets that I showed earlier in terms of how we think about being able to advance the mission of the organization. Our research and reporting arm is one of our core strategies. And it's also one of the strategies that we have some flexibility on. We do have an ability to be able to prioritize and think about what are those areas that are most pertinent to the community, what are those areas where we can bring our unique data and skill to highlight issues and to drive impact. And so where we do have this flexibility, I think it's really important that that flexibility is informed by what your priorities are and what the priorities are of this market and all of the stakeholders in it. And so while we always have, we have an incredible research team, as you all know, and know an endless list of different projects that we would want to work on and think about. This is, I think, one of the great advantages of this advisory council over the years has been helping us prioritize and helping us think about the things that maybe weren't on our list and that should be a top priority in terms of how we can add to the conversation and have action and impact from that. So that will be the bulk of today's conversation. We do have some big topics of things that we have already identified in terms of some core things that we'd like to do this year and get your feedback on that, but also really an opportunity for kind of an open swim and open discussion around that. So in terms of just some housekeeping items before we go into the research discussion, did want to just highlight that 2 weeks ago we did have our public hearing on the setting of the healthcare cost growth benchmark. I think as all of you know, we do have some flexibility during this second 5-year period in the law where the Health Policy Commission can set the benchmark at a number between 3.1 and 3.6%. The default rate is the more aggressive 3.1% growth target. We had a really stupendous hearing 2 weeks ago. We were joined by the 2 new chairs of the Joint Committee on Healthcare Financing, as well as I think about 15 members of the Joint Committee on Healthcare Financing, as well as 10 of our board members, and had a public hearing and a discussion around where we should set the benchmark. I just want to thank those of you who testified and being a part of that hearing, and for those of you who have submitted written testimony, thank you for doing that. And all of that will be on our website, or is on our website as we speak. We are meeting next Wednesday at the Health Policy Commission board to have a vote and a consideration of where to set the benchmark. So that will be next Wednesday. As part of the presentation, we did have some new findings that we released, specifically around the rising cost of insulin drugs and the impact on affordability for diabetic patients in Massachusetts, as well as some new data findings from CHIA, really around continued challenges around the affordability of care for low and middle income individuals. So if you haven't seen those, I'm happy to point you in those directions, but I won't belabor them here today. If there are other perspectives that you think are important in terms of the healthcare cost growth benchmark, be sure to let me know, but we will be voting, I think, next week on that. On the healthcare cost growth benchmark, did want to just highlight, I think, a real credit to Massachusetts and to our history here in being leaders in healthcare, because I'm very pleased to report that a number of other states are now adopting many of the provisions of Chapter 224 and have taken steps to put in place all-payer healthcare cost growth benchmarks, consistent with what our model has been here over the last 6 years. So Delaware, Rhode Island, and Oregon. Delaware and Rhode Island, they're both of their governors issued executive orders to set up a healthcare cost growth benchmark. Oregon is in the process of doing that and may not need legislation in order to actually move that through. But I think a great chance to reflect on and pat ourselves on the back. I don't know that we do that enough sometimes in Massachusetts, but or maybe we do it too much. But it's gratifying that other states are seeing us as an inspiration, and I do want to again say something about this council and how important this council is, because in my opportunity to talk and advise with leaders from these states and many others, they want to know what the magic here is. What's the special sauce that has allowed us to make progress? And I do always reflect on the coalition that we built and sustained over the years, and how everyone continues to come to the table and find solutions and work together. It is a hallmark of how we move healthcare policy forward in Massachusetts. It's the thing that has allowed us to make the progress that we've made, and you are a big part of that. I do get questions from other states about how, does the board, how does the HPC engage with this community, and I talk about the advisory council, and they say, you have 30 people on the advisory council, how do you even manage that group? And I say, you know what, it's fun. Everyone gets an opportunity to have their perspective, and really, there are a lot of voices at this table, but every one of you is really important to this work and to the effort that we're doing here in Massachusetts. So, some great news and progress nationally in terms of our role. And just want to also finally highlight, we did, if you haven't seen it, release a small publication about the role of the benchmark, and that's something that is also on our website. Before turning right into the research agenda, and this is kind of actually a nice segue into that research agenda, do want to just highlight some of the things that are in the pipeline for publication from the Health Policy Commission. And I would say, I think a reasonable timeline to expect everything on this slide, which is slide 16, to be out and published is in the next, before the next advisory council meeting. So I think our goal and hope and expectation is that we'll have all of these things published by early summer. So some of the things that we've already rolled out and had some discussion on the findings publicly include our study of the availability of providers to treat patients with co-occurring mental health and substance use disorder. Our co-occurring disorders brief is hopefully out imminently. We have some profiles on our investment programs. We have a guide of learnings from our telebehavioral health investment programs. But I think in terms of, you can see in the bottom right-hand quadrant here, a number of issues that we have in the pipeline on issues that have already been raised today, which is around pharmaceutical drugs, pharmaceutical distribution channels, the price of these drugs, and so have a report that is imminently going to be released around drug distribution channels, commonly known as white and brown bagging. We have a data points that which is a small kind of blog post type policy brief that we're going to have on the rising cost of insulin drugs. We also have another blog-ish policy brief on the role of pharmacy benefit managers and some variation in the prices that they're charging for generic drugs. And then finally, a new mandate that we have, relatively new mandate, is a study on the impact of drug coupons in the Massachusetts market. And there is an aggressive timeline on that study that is intended to influence the public debate about whether the Commonwealth should continue to allow for the drug coupons or copay assistance programs in Massachusetts. Massachusetts, as many of you may know, was the last state to authorize the availability of these types of assistance programs. So I'm going to just pause here quickly. If there's anything here that people want to have a question about or want to have an interest in, feel free to speak now, or otherwise I'll keep moving. Okay, great. So lots in the pipeline. So shifting to our research agenda for the next year. So on slide 18, this is a long list of bullet points of different things that are currently in the hopper in terms of our research team's agenda. Some of these are definitely follow-on pieces of work to previous pieces of work, and that is certainly something that we do, where we'll have an initial investigation and then go deeper to try to understand some of the drivers of some of these issues, as well as some new areas of work. So insulin price growth, and the first two I've already mentioned already. Out-of-network billing was mentioned earlier by Erica. Continues to be a policy priority for the agency in thinking about the impacts that this has on consumers, how often this is happening, and what the, getting some more data behind this phenomenon, and continuing to push that agenda. In terms of workforce, one of the things that we're interested in pursuing and trying to understand a little bit more is the role of nurse practitioners as primary care providers in Massachusetts. We did pass a law over a decade ago, I think at this point, that allowed for nurse practitioners to serve in the role as a primary care provider. And we want to learn a little bit more about how that has evolved, how often that is happening, are different organizations using nurse practitioners in different ways, and how often something that we want to try to investigate a little bit more is how often these nurse practitioners are truly acting on their own and billing insurance companies on their own, and how often nurse practitioners are still billing through a physician, which is what we refer to as incident to billing, and that they would bill underneath the physician's license and bill at the higher rate of the physician. What are some of the quality impacts of nurse practitioners and improvements in access? How do nurse practitioners play a role in serving underserved and vulnerable populations? So a little bit early in that, and happy to get some feedback on that as this discussion today. Continued work on kind of waste and low value care, drug coupons I've already mentioned. We are planning to have an update imminently around opioid-related hospital visits and emergency department visits. This is a study that we did a couple of years ago. We're going to update this with some new data from 2017 to continue to see the impact of the opioid epidemic on the healthcare industry in particular and on hospitals. And then finally, as was mentioned before, we're working with CHIA on a survey of avoidable emergency department use to understand some of the root causes of why Massachusetts residents are seeking care in that location, and do they know about availability of care in other locations. So there's a lot on this list, but I suspect there are a lot of other things that this group would ask us to prioritize and to think about in terms of our research agenda. So I'll pause here before we do a deeper dive into one of the big areas that we want to work on, which is administrative complexity. And Ron, you mentioned physician burnout, and that is, I think, one of our major research goals for this year. But before shifting into that, first looking for some reactions to anything that you see on this list in terms of saying, yes, that should be a priority, or to say, David and the team and the Health Policy Commission would really encourage you to look at some of these other areas. So with that, I'll pause and I'll pick on Marcy. I already see you reaching for the microphone. I'm not surprised you have some input, so why don't you get us going?
Thanks, David. It's a great list. We'd be delighted to participate in the primary care providers using EPCs, both nurse practitioners and PAs. We started doing that several years ago and have been growing the number and been delighted, and we don't do incident to billing with them. So happy to talk to you on that front. And I would encourage you also, as you look at that, to look at the scope of practice legislation that's currently out there. We are so far behind other states in allowing nurse practitioners to practice without having to have a prescription license with physicians, and we've supported that for quite some time. So you might look at scope of practice there as well. We also would be interested in looking at the role of OB/GYN as PCP. We really are going to have a huge shortage of primary care practitioners, as Ron mentioned, and thinking about how many women get their care from their gynecologist. That may be quite an appropriate direction for us to move in as well. And then I think you did phenomenal work with the oncology drugs, and I would encourage you to continue to look at the cost of oncology and price variation in that arena, as well as understanding survivorship and what that means for the likelihood of costs going up in coming years.
Julie?
Just echoing on the nurse practitioners on the scope of practice, I hope that you are going to do a comparison on the other states and how we compare to them, because it's quite different from state to state. On the EDs, I assume you're going to include in also along the way the variation in the EDs, because there's been a tremendous amount of changes in the emergency departments, including build-outs and whatnot, so I think that affects the EDs. And I don't remember, but I assume you already did, but I just in this moment can't remember if you already looked at observation beds.
We have not done a specific study on that.
Because I don't think, well, to that point, I don't think you can look at the emergency department without looking at observation beds too. I think those two things have gone hand in hand. And then lastly, on the primary care physicians, the issue of looking at primary care physicians, also in conjunction with the continuity of them, there's a numerical issue, but also there's an issue of the transition of the primary care docs. So I'm saying if you manage to get enough primary care docs, but you can only see that primary care doc for 3 years because they moved to another state, I think it's worth looking at, are we really getting the benefit of primary care by continuity of the individual, or is it just the title?
Thank you, Julie. I'm going to pause here on this conversation, because I do think this is an area that we're actually looking for a lot of feedback and guidance in terms of. I think the word workforce was mentioned, probably 15 times in terms of the opening introductions, and it's one of the things I'd love to get a little bit more feedback on. So maybe let's dig a little deeper into that. What could the Health Policy Commission? What is our role here in terms of highlighting some of the challenges that we know exist? Highlighting some of these opportunities. I think, as was mentioned, I think we. Grasp this primary care nurse practitioner and advanced nurse practitioner role, and that evolving role as being kind of a sweet spot in terms of both a workforce issue, but also an issue that has very clear cost and quality and access components to it. And I think, Julie, to your point, even beyond nurse practitioners in terms of thinking about. What is the workforce in primary care generally, and how is that evolving and changing? We did make a recommendation a number of years ago to remove some of the what we would say are outdated restrictions on the scope of practice for nurse practitioners in Massachusetts. We lag many other states in terms of our allowances for these professionals to work at the top of their license, and that has not been something that we've seen progress on in terms of a policy agenda, and want to continue to highlight that issue. But interested in hearing from others in terms of, if you were advising us in terms of what our workforce agenda could be and should be, recognizing that there is other state agencies and other efforts underway, what would you advise? David, you mentioned workforce, and so maybe I'll call on you first.
Thank you, David. For my area, we literally, this is psychiatric and primarily psychiatric facilities, we literally cannot find the psychiatrists that want to work in our hospitals anymore. I have scores of empty beds and units because we don't have the physicians. We also need nurses, and I would encourage you to look at the access to behavioral health and how that could be impacted by better utilizing advanced practice nurses, whether it's nurse practitioners or other forms of nurses. We filed legislation this session that will be in the hopper to address this. That's how bad it's gotten for many of my facilities. So if you can expand it to behavioral health, we have, as you know, emergency room backups, boarding, and we have, at the same time, we have empty beds because we can't find the staff. So it's a problem, and it's Dr. Dunlap, it's probably going to get worse. So we're really in the future even more concerned. So thank you.
Along the same lines, being in a rural part of the state, it gives you a different perspective on the challenges that we have. we can't recruit doctors. We can't recruit APCs. Patients have no access. There's no public transportation for them to even get to a clinic, even if there were primary care physicians available. And we have no internet in some places, no cell phones, so we can't even implement telehealth. So I think there's an opportunity, however, regardless of those limits. And one of those would be to actually take care to where the patients are, to actually mobilize the medical facility to create clinics that are actually mobile. I think one of the reasons why we have such a high mortality rate from opioid use disorder in the rural part of the state is because they have no access to behavioral health. You can't do it like our health. They have no MAT treatment access or follow-up. So the strategy has to change. We can't really think that we're all living in the Boston area and patients will come to us. It is likely that we're going to have to mobilize the medical care to get to the patient. And I think that's a big challenge because there's a lot of upfront cost that is not going to be realized in the patient. And how do we get that support? How do you justify it financially when there are so many competing interests?
One thing those are great points, and to both of those points, we have this report that's going to come out soon on the availability of providers who can treat patients with co-occurring disorders. I think highlights some significant challenges that the Commonwealth is facing for that particular really important connection between mental health and substance use disorder, and in places across the Commonwealth where people have to drive 25, 30 miles, to even see some of those providers in areas where public transportation is very limited, if existent at all. So I think some of that will help continue to highlight the challenges. I hope that in some of these things, it's not just highlighting the challenges, but starting to think about what are the opportunities for solutions. So I appreciate your comment on that. Marcy, and then I'll jump in.
Just to add on to David's comment, clinical pharmacy is another area. They really should be billing providers, and there's a bill in front of the legislature now on that. We're using clinical pharmacists to do collaborative disease treatment management with one of our psychiatrists. I think that's going to be a very promising way to supplement the psychiatrist for people who, are a little more manageable. So I'd look at that. And then if you're looking at primary care team, there are so many new kinds of care providers who are not licensed but are difficult to find. So medical assistants, there's a growing need for particularly certified medical assistants. And then if you look at care facilitators, we use them in both in behavioral health and in pediatrics to help with connecting people with care with the community. Community health workers, I know there's been a lot of attention paid there. And then population health and data analysts is another area where there's a growing need and seem to be great ways to keep our college students to stay here in the Commonwealth.
We have a number of workforce issues. Two I'll just mention. One, you already mentioned scope of practice issues, particularly for nurses in the community, and we have some initiatives on that that I'd be happy to bring forward. But I also want to talk about, I've said this before at this meeting, we never talk about end-of-life care at this group. And what we are looking at in Massachusetts, we have a mandate for certain practitioners to refer people with serious illness to palliative care. But we don't have trained community-based palliative care workers. We are trying to retrain nurses, particularly for palliative care, and the whole intersection of cost of care, that's a touchy subject in palliative and end-of-life care, but also better care for patients when you have trained palliative care specialists, and that's the issue we're working on.
Yeah, that's a great point, and just strikes me as an opportunity to tie in the last two comments together, where in some of our grant programs and in our investment programs that we've been able to fund organizations to do innovative work, the care team that they've been able to leverage to make a difference for some of these extremely complex patients includes all of the different professionals that you just mentioned. And some of our most successful grant programs have been with care teams that included a clinical pharmacist as part of the care team, that included palliative care as part of that care team, a palliative care nurse. And those, we've seen some tremendous results in terms of being able to improve the quality of care and reduce costs and get care in the right kind of place. So I wonder if there's an opportunity for us thinking about where we have some examples in our own work with providers to say, here's how these individuals can be a really critical part of the care team, and then translate that into a broader statewide policy of like, okay, how do we make this not just at a grant program at this one site, but to encourage others to scale and expand those roles. That's a great point. Anyone else, on kind of specifically on the workforce things that people want to raise, Ron?
I was very interested in health equity in terms of mental health. So I would encourage you to look at access to mental health by income group, because I had 25 years of emergency room experience just to keep my hand in, and I started out at a hospital in Cambridge where there was a facility right there, but basically, if you're lower income, you get a mental health record. Your access to a psychiatrist is quite limited. So in the past year, I've joined the board of Martha's Vineyard Community Services. They had that problem, and they actually brought the private providers, the psychiatrists together with the people who run the clinics. They all would ordinarily badmouth each other, but they actually got together and worked out a system to be able to work together to provide mental health, because that population there, the year-round population, is really quite challenged in terms of social determinants of health, income, et cetera. So there are ways to do this, but we really need to analyze the system, because it's largely the concierge thing when you start to look at psychiatrists in the field, and that's really quite critical.
Yeah, that's a great point, and something I probably should have said at the outset, that I think across all of these different research topics, an interest in diving deeper and to say, look at on any one of these issues, on insulin price growth, what is the impact on some particular subpopulations? What is the impact on people with different race and ethnicity, different income levels? And so bringing some of those different variables into all of the research work, I think, allows us to get a little bit deeper and to understand where there are persistent inequities and disparities in terms of access and quality. So something that I think we have a commitment to try to weave even stronger through our work moving forward. Sure? Okay, it's fine.
So thinking about the insulin price growth issue is so critical, and I just would also recommend, in addition to looking at spending, if we could get access to claims data and start to connect this also back to utilization changes, as well as outcomes in terms of disabilities and things like that. I would be very excited to help with that, as well as some of the other issues about stratifying the data for movement subgroups. And then additionally, the avoidable ED use. Since you're doing resident surveys, I'd be really happy to help with thinking about tools for assessing the health-related social needs, and also just narrative and how to think about, if you're doing the survey, the qualitative sort of inquiry, kind of get broader themes around what sort of is driving this, including subspecialty care, some of the things we talked about today around mental health. So I'm happy to help in both of those areas.
Thank you for volunteering. So I think this is worth shifting a little bit to the pharmaceutical and drug issue, because that was, again, something that I heard from a lot of the different members here this morning as being a priority. Dr. Clark, I love what you said, and this is, I think, one of our dream aspirational goals, is to think about the connection between the rising cost and price of drugs and how that's maybe impacting adherence for patients. Are they, not adhering to their insulin? Is this causing even further downstream effects? And I think, to be fair and to think about this on the opposite side, where there are new drugs that are new innovations that have really good clinical value, connecting that to perhaps reductions in downstream costs if people are adhering to their drugs and being able to have access to them. Reduced hospitalizations, reduced ED visits, things like that. So I think connecting the pharmaceutical issue to the whole person and to the whole healthcare system is something that I think will we'd like to try to do and not just look at it in isolation. But interested in other people's thoughts and advice. As mentioned, we got a lot on the hopper on some of these drug issues, but also interested in, since many people mentioned this as a priority, what other things people would be interested in us pursuing.
We've talked about it before, Dave. We talked about, heard a number of people mention value-based purchasing, and so for pharmaceuticals specifically, we talked before about exploring what barriers are in place for there to be more innovative contracting, more value-based agreements between the companies and the plans, where the price of the product fluctuates based on the outcomes it delivers. And so incorporating real-world evidence, incorporating being able to match what happens in the real world versus what the clinical experience was. And so in that way, both the plan and the company have a lot of skin in the game. We're not just reimbursing based on volume by unit, but rather by, we believe it's a highly differentiated product. If we deliver these outcomes, then the price of the drug will fluctuate whether it really does or doesn't. And that also means that both the plans and the companies have a lot more skin in the game when it comes to things like adherence, ensuring that it goes beyond receiving a prescription, but the patient taking them to happening over the course of the long term. There are regulatory barriers in place that prevent you from doing this in the public space in particular. But we have good examples. We talked about this hearing a couple years ago at Harvard Pilgrim and others that are beginning to try these kinds of methods. So I'm sure we will talk about all these standard policies we're used to talking about, but I think it's also worth the HBC at least exploring what are other opportunities whereby the value of the product can be better articulated and the price of the drug set accordingly.
Yeah, certainly the value-based contracting has been a recommendation in our cost trend reports. You know, one of the things I'd love to maybe work with you and maybe with the health plans on is to try to get a little bit of better understanding of how exactly those contracts work. How much risk are we actually talking about in terms of tying payment to clinical outcomes? And my sense is that there's some variability right now in the market in terms of how those are structured and understanding that they're very confidential at the same time and protected. I wonder if there's still nonetheless ways, maybe without naming specific companies, that we can say, here's a good model for what a value-based contract might look like, and here's maybe not to be dismissive, but kind of putting value on a contract that otherwise doesn't really have much risk.
We'd be very happy to do that. And again, we can kind of talk. There's different kinds of innovative contracts, and we can do that sort of by taxonomy of different kinds of contracts without getting into the details. But we'd be very happy to participate.
Or
We'd be happy to engage in that conversation. I think for our members, value-based contracting has its place, but we don't think it's a replacement for this issue around drug costs and what we're seeing in the market and the impact that's having on prices. On out-of-network, surprisingly, that's emerging as a really huge issue for our plans, along with facility fees and for our members. And particularly around ambulances as well, so I don't want to lose sight. We talk a lot about the wrap providers, but it's also insured ambulance. Ambulances and charges there, so I wonder if you're going to look at that as well when we think about the network. And then facility fees, part of this.
Yeah, so two quick things on that, and then Alyssa, I think you wanted to jump in on the drug piece. So we did do a study a couple of years ago looking at the claims data in terms of the prevalence of what we could observe in terms of out-of-network billing. We were had some limitations on that evaluation. We only had 2 health plans and had kind of robust data that we could look at. What we did find was that of all of the instances where it appeared that there was an out-of-network claim, 90% of those were in ambulance and ERAP providers, emergency radiology, anesthesiology, and pathology. We'd love to, that data was, I think, off of 2015 claims data. I think opportunity to refresh that and to add some more health plans to get a more robust sample. I think what we found was in many cases the health plan, actually in the majority of the cases that we observed, the health plan is paying the full charge to the provider. And on one respect, that is a good thing in terms of keeping the patient out of potentially having to face that big bill. On the other hand, we do know that the charges that the health plans are paying are multiples of what an in-network rate would be, contributing to higher spending and higher premiums essentially for everybody. And even in the sample that we looked at, it appeared there was about, and this was a limited sample, so this was not representative of the entire state, about 10,000 instances where there were some of these out-of-network bills. And that may seem small to some people. I would posit that that's 10,000 too many in terms of potentially putting the patient and the consumer in the middle of frankly a billing dispute between the health plan and the provider. So we do need better rules, and there are great state models that we can pick from and emulate from.
Paying charges to these guys.
Alyssa, did you want to jump in on the drug stuff?
Yes, thank you. So a couple of thoughts on the pharmaceutical piece. First is reiterating our support for looking at the impact of high and rising drug costs on adherence. We hear about this frequently from individuals that call our helpline, as well as speaking to partners throughout the state who are, talking to consumers every day who are struggling to pay for high drug costs. So just want to say thank you for being committed to looking at that, as well as looking at, how adherence is impacted and access is impacted when these new drugs are hitting the market at very high price points, which, we say, drugs don't work if people can't afford them. And so we really understand and appreciate the need to invest in innovation, but if these innovative drugs are not accessible for individuals, we have problems. The second piece is that we sort of in all of our work thinking about value of prescription drugs have encountered some various perspectives on sort of how to measure value and have heard some concerns from partners in the disability advocacy community around the Qualis measure, and I think we are trying to sort of sift through what this all means and would appreciate any help that the HPC can provide in sort of helping figure out, how can we measure value in a way that's, looking at what a fair price can be and all the wonderful work that ICER's been doing, but at the same time not devaluing the lives of people with disabilities. And then the third piece is around academic detailing. So I believe HPC has kind of a small pot of money from last year's budget to do some kind of small academic detailing program. So if there's any kind of case study or any research findings that you can share from that work, that would be wonderful.
That's great, thank you. And if you could define value for us, that would be
yeah.
Thank you. And just a small plug there, we did have $150,000 in last year's budget to do an academic detailing program, which for those of you who don't know is an objective educational program for prescribing clinicians and professionals. We are in the contracting phase with an organization to get that pilot launched imminently, and do expect to be able to work with hopefully 5 to 10 ACOs in that work moving forward. So for those of you who are working or represent ACOs, we'll be in touch with you about that opportunity. Bonnie?
I just wanted to go back to the out-of-network discussion. We would just like to encourage that the definition of out-of-network billing be quite expansive. I think the inclusion of the facility fees is very important, but also in the mental health care field, patients that have providers that do not accept insurance. When that patient is reimbursed by their insurance company for a fee, they are only reimbursed, at the rate that they are that the company would typically pay for that session, and then they are out of pocket the difference. So if a doctor is charging you $200 an hour and your insurance company is going to pay $100 with a $25 copay, you're paying out of pocket $125 an hour for that session, and only $25 of it is going towards your maximum out-of-pocket deductible. And so that doesn't seem to fall into any specific category, but it really does work in a manner similar to out-of-network billing, and it's something that's really been ignored and is a major cost to patients dealing with mental health care.
Thank you, and that is a perfect tee up. I'm just going to ask Donna Mosh to just introduce herself really quickly. Thank you for joining us, another new member of the Advisory Council.
Hi, good afternoon. I'm Donna Mosh from the Massachusetts Association for Mental Health. My apologies for being late. This was the first meeting and I already had a commitment to chair something till 1 o'clock, so I ran up here. So thank you very much. I'll be on time in the future.
Wasn't calling you out, just wanted to recognize your participation. Thank you. Thank you for being here. And just to give you a sense of the conversation, we're just talking and reflecting on some research priorities for the agency for the next year, and have talked a little bit about workforce issues and pharmaceutical issues, and interested in getting further feedback. So that's where we are in the conversation. Yeah, Ronnie.
So can I shift back to a comment from Dr. Clark? This is around avoidable ED use. I was really excited to see the last words in that line be about root causes. So I just want to reinforce Dr. Clark's comments about what I take to be about not just looking at what we might have avoided, or whether patients are aware that there are other places to get care once they're sick and urgently sick, but potentially what patients, are they aware of resources to keep them well, and do they have access to both preventive care and to the health-related social needs that they need? And including that in the resident survey, I think would serve us really well.
That's a really great point, and definitely something that we're contemplating as part of it. Yep.
We mentioned earlier about the out-of-pocket spending. All my patients complain about. But I think, the other piece that I see in my region, and probably that's ubiquitous, is the urgent care centers that are popping up everywhere. Those for-profit centers are actually adding cost to the system. And I wonder if there is a research avenue to look into what models would actually reduce costs once we factor in these urgent care centers. If these urgent care centers need to exist in a free market, they probably should, how can they actually function in an integrated way within the existing healthcare system? Because right now they're costing more. Patients show up, they don't understand actually what an urgent care center or a CVS can offer. They pay for that service, then they're referred to an emergency room for additional services and tests. They pay for that as well. That's a very common and recurring issue.
Yeah, we did do an initial research into the field of urgent care, and I think one of the things that struck us is that even from a government lens standpoint, there's not a clear definition of what an urgent care center is, what types of services they provide. We understand that there's a lot of variability in what patients can expect when they go to urgent care centers, a tremendous amount of variability in terms of their connection to the healthcare system, and certainly some of the bigger health systems are now building their own urgent care centers that alleged to be more integrated in terms of an electronic health record and things like that. But that is, in terms of a market dynamic, that is a big one that we've been following and tracking, and we expect to continue to do so. So, Steve?
Yeah, just pick up on the word, you just said the word allege. I think the big systems that are creating urgent care are absolutely to provide better care for their patient. And when we look at a lot of what's on your list, my concern is that we're conflating a bunch of issues. Like, it's easy to take facility fees and say, well, let's eliminate those. But if you're keeping your emergency department open for anybody that might show, you might need a facility fee in certain services in order to be able to offset the cost of running that ED. An urgent clinic that doesn't take mass health doesn't have to worry about that. So when we talk about avoidable ED use, by the time they get to the ED, it's too late. Avoidable ED use, there's so many steps before that. So if we don't want to tackle telemedicine or mobile integrated healthcare or pipeline issues around the workforce or nurse practitioners, as Julie mentioned, or increase access to behavioral services, they're going to show up at the ED. So if we just take that issue and say we're going to do avoidable ED, so that means EDs are going to close, and then what happens? So all of these things I think we have to look at through the patient lens of how did they get to the place that they ended up. And I know you say that in terms of trying to understand the root causes. But if we were to just attack any one of these issues from the provider perspective, we would do incredible damage to the system and to its neediest residents. Limited service clinics that are unaffiliated from a hospital are not showing up in Lawrence. But Diane still has to treat every one of those people that walk through the door. And then this issue around two-sided risk. Providers would be happy to take on two-sided risk. It is the future. But we're not getting any of that reserve. So we're having to build reserves on our own in order to be able to accept the risk that will be necessary to move to the ACO world talk about. So I guess, as I look at the list, I think it's a perfect list. You continue to do the great work you always do. You already did a good job with the urgent care stuff. But I think we have to look at them holistically and not say, well, let's just eliminate this issue or that issue, because they're far more complicated, I think, than just taking them one at a time. Out-of-network billing oftentimes is because they're in a rural area and that service is not provided in the community hospital, and a patient comes in need of help at that moment, and they get that help from a doctor that's out of network. And none of us would ever suggest that we don't help that patient. We just have to collectively figure out how to appropriately pay for the service.
Yeah, I take your comments to heart, Steve, and I do think that there is always a danger in just putting a list of topics on a slide without having a sense of what is a broader framework in terms of what we're trying to accomplish. And I accept that challenge in terms of putting it in the context of a broader healthcare market that is undergoing a lot of transformational change and is very dynamic. And, you know, I guess a little bit of pushback would be at some point we get so big and so broad that we become paralyzed to take action on anything. And so there is, I think, a healthy balance in terms of putting it in a broader context, but also thinking about issues where we can dive a little bit deeper and get a better understanding of what those dynamics are.
Just stick with Barbara.
Sorry.
What's the data you're using for that PDM? Is it ABCD, the PDM research project?
Yes. Well, actually, no, it is not. It is.
It's publicly available data from NADAC on the acquisition cost of drugs, as well as for a Medicaid component. If we could use publicly available data published by CMS. But if we did a commercial component to the analysis, it would also be from the ABCD. Great, thank you.
Laura, did you want to jump in? That's not like you. Okay. We only have 10 minutes left here. And there's, as typical with these meetings, there's 40 other slides that we haven't even looked through. But I think it's probably, I will say something to both of those projects at the end of this conversation. But other topics that we haven't mentioned yet today that you would urge us to keep in our work and as we think about this agenda. I'm looking at our three business representatives all seated together very helpfully. Thank you. And recognizing and one of as I mentioned to Chris before this meeting, this was a highlighted concern both at the cost trends hearings and in our report in terms of the rise in premiums, especially for smaller businesses, but generally, and affordability challenges and how those play out, both in businesses, but then ultimately translate down to consumers and patients. In some cases, businesses faced with some of these premium affordability challenges are turning to high deductible health plans at a greater rate, and those have downstream impacts. So I wonder, any one of you, if there's anything that you ask us to continue to think about. John, I can probably guess what you're going to say, but.
I have to say it because this is what I come here to do, right? David, I guess if there was one thing that wasn't there, one bullet, I guess I would just argue that sometimes it's helpful for government to look in the mirror and take a good look at itself and look at its policies and what has it done to fairly distribute costs amongst all the payers. What have the rules, the playing fields the government has set up in terms of risk pools, rating factors, state mandates, how utilization, have we really looked at utilization and how those costs are fairly distributed amongst all of the different forms of consumers? And are there groups, frankly, out there that are paying far more than their fair share so others can pay less than their fair share? And I mean, small businesses, they compete every day for customers and employees versus big businesses and versus big government. Yet we put them at a second level of consumers. And I think we need to start looking at why are their premiums higher, yet virtually all of them are at high deductible plans. And we can continue to ignore it, or we can look at the real problem in healthcare here in Massachusetts.
So thanks, John, and I do think an area of investigation for us, and certainly we had a lot of questions last year about, well, what is going on in that market? Like, what is happening? Is this a more acute, a sicker population? Like, why were we seeing a divergence, especially between Massachusetts and the United States on small business premiums in particular? And I do want to highlight, and I think an area of interested interagency collaboration is also the experience of the Connector, where they have been able to have a tremendous value in terms of the premium that they're providing to small businesses, and what is unique about that market that maybe we want to think about extending to other markets as well, where we have among the lowest premiums in the country available on the Connector. But Chris?
I think, David, that was one of the reasons I wanted to be a part of this the most, is when you see small businesses facing the second highest cost in the nation. I mean, that's alarming. So for my members, it's just a huge concern. I mean, for the past decade, it's their top concern, and it's going to continue to be until we start to address it. So anything that we can look at here that will help to start chipping away at that will be very beneficial for employers.
Laura? Thanks, Chris.
Actually, thank you. I don't know if it's outside of the scope of the program, would be helpful. We did a paper last year about why small premiums were different, what's going on, the cost benchmark. A lot of it's the additive assessments, the mandates. It's also, I wonder, as we're seeing more and more plans, more and more folks self-insure, if we're starting to have a little bit of adverse selection in the emerging market, where folks who are too sick and doesn't benefit from staying in the fully insured market, and healthier, younger people self-insure. We're seeing it at a smaller group level. There are lots of reasons, and the comments are right on, and if it's within your scope, it might be interesting. And we did some of that in the paper last year, trying to explain it.
Yeah, we'll definitely take a look at that paper, Laura. Thank you for that. Margaret, and then Mercy.
So to Steve's point, when he said by the time they get to the ED, it's kind of too late, to see something specific, because I know we speak to and mention social determinants, but what impact they have on cost avoidance. When the Commonwealth looked at the home and community-based services, they looked at the population saying we saved hundreds of millions of dollars. So how do we look at that and then the offset when you're putting dollars into those types of services? It's a little harder to measure because you're looking at the negative, what didn't occur.
Thank you.
It would be great if you could perhaps get ahead of and model some of the things that the legislature might be considering relative to their health care bills. And I'm thinking in particular of two areas. One is, I think we would all agree that it's really important to preserve our community hospitals, but some probably more than others. And so helping maybe provide some framework as to how to think about that. And then the other place is in the area of price variation. We're really concerned that arbitrary formulas are not going to have the intended impacts, and so trying to model out, what does it mean to cut off the top and raise the floor and that sort of thing. Having some data behind any of the things that are being contemplated would probably be of more value than almost anything else you could do this year.
You want to add something to that, Laura?
Yeah, I want to really echo what Marcy said. We obviously have done our own modeling in our plan, but also, what are we trying to do for community hospitals? Are we trying to ensure that certain community hospitals that might have financial problems, need to be supported, or trying to help the whole group of community hospitals besides what proposed in the legislature? I'm not sure the issue is going to go away, but we've done a deep dive into the analysis and the finances. It's as clear as mud, so that might be a really great place for the HPC and CHIA working collectively to examine.
Yeah, Diane?
Thank you, Laura and Marcy, because I did not have to bring it up. But I think that, your point of preserving our high-value community hospitals is really very, very critical, because we play, and many of them are represented here today, play a very, very important role in providing high quality and high acuity care at a much lower cost. And every day, last year there was such outstanding work by the HPC and by others in advancing a fix to price variation. At the 11th hour, we couldn't get through, was not successful. We can't take our foot off the pedal on that. It has to stay very much, very, very much in focus as far as needing to get done. Because quite frankly, every year nothing is done about that, erodes these very hospitals that provide so much value.
Thank you, and I think with the last 2 minutes here, I just wanted to highlight what's in the rest of your deck, and we won't have time to talk about it today, but these are our two kind of bigger projects that we have on the docket, and something that I think I would hope that we put back at our next advisory council meeting and maybe spend the majority of time talking about. One is a project to try to identify and document the areas of administrative complexity in our healthcare system that are truly not really providing value. This has been a consistent and persistent theme across our cost trends hearings and growing to what was a murmur to now a loud scream for help from our healthcare system in terms of the impacts of physician burnout and really just a reflection of not just something in Massachusetts, but the United States in terms of the complexity of our healthcare system and how that adds to cost and how that impacts patient care. And so, Ron, you mentioned this in your opening statements, and I know this has come up on many different times. This is a big project. This is a huge undertaking. And so what we really want to do in approaching this is first talk to all of you and think about where you see those particular pain points in terms of navigating the healthcare system that, again, are areas that are not really providing value in terms of patient care. And if we could free up those resources and time and energy and devote that to the quality of patient care and dealing with some of these persistent challenges, an opportunity to really advance our healthcare system in Massachusetts. A big project and something that we will be calling on many of you to help us identify those particular areas. The second project is something that we have done consistently over the past, which is look at the post a transaction, post a merger or consolidation. What do we see in terms of the impacts of those market changes? And we've done this kind of on individual mergers and consolidations. We've done this through our cost and market impact work. I think what we're contemplating here is something a little bit broader, which is to say, how in the last 5 years has our healthcare market changed, and how has the delivery of care changed? What are those impacts, and where do we continue to see areas of market dysfunction? And I think the role of community hospitals continues to be something that is a huge challenge. How community hospitals treat patients with both high acuity and patients with low acuity care. And I think to your point, to many of your points around the role of community hospitals, we did a report, kind of on the state of community hospitals a couple of years ago, community hospitals at a crossroads. And I think there's a great opportunity to update a lot of the analyses in there and see if we've actually made any progress in dealing with some of those underlying tensions and dynamics. So not more to say on either of those. Those are two big topics, but I'll hope that if you are interested in either of those, that you will reach out to us, connect with us, and be a part of our research team as we advance those projects moving forward. So with that, we are right on time. Our next meeting is in July, but as I said, please be in touch, and we will be in touch with you. So with that, thank you so much. And Commissioner, I don't know if you want to add anything here at the end.
Thank you very much for such an enriching and enlightening conversation. David suggested I come to at least one of these meetings. I'm fascinated by what you have to say, and I think I'll probably be back. We'll probably see you in July. Thank you.
Thank you, everyone.